Now, we know what some of you might be thinking. This isn't really a journal article. It's more like a framework or an outline. And you'd be right. It's not a study. It's not packed with p-values or Kaplan-Meier curves, but it's one of the most important documents shaping how we educate ourselves and our teams about safe opioid use. Why is this important for a journal club? Because the blueprint doesn't just exist in a vacuum. It's already influencing your CE and CME content, inpatient and outpatient treatment protocols and workflows, and even your conversations with patients and caregivers. So today we're going to do something a little different. We're going to bring the blueprint to life by exploring real-world pain management scenarios and best practices in approaching them, what the blueprint says about opioid safety and misuse, how to apply best practices from CDC opioid guidelines, and how to have better conversations with patients about risk, alternatives, and naloxone. Whether you're in a hospital setting, an outpatient clinic, or a pharmacy, we hope this will feel relevant and practical. Let's start by talking about the different types of pain. So, one category of pain is nociceptive pain versus neuropathic pain. Nociceptive pain is the pain that most of us think of when you close your hand in a door or you accidentally stub your toe. It's really pain that happens when you have injury or pressure on any part of your body. Neuropathic pain is a little bit different, and that's pain that often results from injury or pressure on a nerve itself. So when you think about radicular pain, or pain due to a herniated disc, or pain due to a nerve injury, that pain, that neuropathic pain, is often more electric or shocking or stinging, whereas nociceptive pain is normally very pinpoint and sharp. If you think about a paper cut, that's a good example of a nociceptive pain. Two other ways to categorize pain are acute and chronic. So acute pain is pain that's, I would call, functional pain. So acute pain is pain that you experience as your body heals. So if you have an injury or a surgery or a broken arm or a stubbed toe, that pain should resolve over time. That pain normally heals in weeks, but in general, acute pain normally resolves within 3 months. Chronic pain is actually when you actually have changes to how you perceive and process pain. I often call that dysfunctional pain, pain that persists even after your body heals. And a lot of times there are kind of mechanistic changes that happen at the neuron level that affect how we process pain. So when you have pain over and over and over again for a long period of time, we often say that this transition happens at 3 months, but it can happen anywhere in the process. It actually becomes easier for your body to send pain. So your body adapts to this idea of having pain all the time, and it actually puts in more receptors for to allow pain signals to be sent. It actually makes the transition of action potentials easier so that you can send signals from your periphery to the brain easier. There's also, when you look at the biopsychosocial model of pain, there's also changes that happen kind of on the mind side of human existence that also make pain a lot easier. Often pain over time becomes coupled with depression and anxiety, and catastrophizing, and those loops feed on each other. So the more depressed we are, the more we feel pain. And the more we feel pain, often the more depressed we become. And patients who have depression or anxiety, or who catastrophize, or patients who have certain genetic predispositions may be prone or are often prone to developing chronic pain more often than patients that don't. So when we encounter patients, especially patients who have chronic pain, we often historically have been very focused on the VAS score. And when we focus on the numerical pain score and we make that our North Star, we often make mistakes in alignment of what patients' goals are. And I've found that that leads to the overprescription of opioids. Because if our goal is to get patients down to a one or a two on the pain scale, we often will continue to prescribe medications, even though patients may be satisfied. A lot of times, I've found that patients normally have a functional goal in mind. Patients, while pain may bring patients to the doctor, patients normally come to the doctor because pain has interfered in their life in some way. And they're trying to get back to some activity. That can be playing with their grandkids, that can be going to the grocery store, that can be going to the gym every day. And so I find that the number one goal when working with patients should really be their functional goal. And so whenever I establish a relationship with a patient, I often ask them, what is the thing that you used to be able to do that your pain is preventing you from doing that you want to continue doing in your day-to-day activities? And when I find out what that goal is from a patient, I make that our North Star. And so if a patient says, I want to be able to go to the grocery store, then I'm able to tailor their plan. And that plan may be acute things they can do before they go to the grocery store, whether that be get a shopping cart, whether that be stretching, whether that be working on that particular goal in physical therapy to ensure that we're doing everything we can to get patients to that goal, not to a pain score of one or two. And I think that importantly brings in the team-based approach. And so as we're creating that goal, it's not just me that's working to get a patient there. We're creating a team because that patient and I are going to be working together. But not just the patient and I, we're also bringing in their physical therapist. We're bringing in their pharmacist. We're bringing in their family. We're bringing in other members of the healthcare team, whether it's nurses, nurse practitioners, or other physicians that that patient is seeing, to really understand that we're all committed to helping that patient get to their goal. And so when I write prescriptions for physical therapy, for example, I'll often put in our typical, two times a week for 8 weeks, focus on low back strengthening. But sometimes I'll put things like with a goal to get the patient to get back to walking 1 mile a day, because that may adjust the physical therapist's mind and adjust the physical therapist's plan to align them with both me, the patient, and the rest of the care team. As we see these patients back, I feel that we should really assess where we are with these functional goals every time we see patients. We use promise scoring in our practice, which is a questionnaire that looks at multiple kind of paradigms of how pain may affect someone's life. So that includes sleep, anxiety, physical functioning, pain interference, and others. And we have patients take that survey every time they come into our practice. So we can trend not only their pain score, we can trend how their sleep is doing, how their function is doing, how their anxiety is doing, how their depression is doing. Because in the biopsychosocial model of pain, all of these are important and all have effects on how that patient experiences pain. And so when I meet with a patient, if that patient's goal is to walk 1 mile a day, I may say, how much are you able to walk so far? And that gives me a goal, or that gives me a read on how well what we're doing or our treatment plan is working.
Treating pain in pregnant and postpartum patients can especially be challenging. I had a patient, for example, who was pregnant unexpectedly and who was on chronic opioid therapy as well as a variety of other medications that are contraindicated in pregnancy, antidepressants and benzodiazepine and ketamine and all sorts of medications. So it was a big surprise when she all of a sudden became pregnant. And so, what we did in that situation was I worked with her OB as well to come up with a pretty quick taper plan to get her off of those medications, prioritizing the ones that were most potentially harmful to the baby. And we were able to get her off of almost everything within about 4 to 6 weeks. And what we kept on board was an occasional hydrocodone acetaminophen for pain that she actually rarely used. Certain pain conditions, actually, we see improvement in pregnancy. This one particular patient had complex regional pain syndrome, which is a very interesting pain condition that involves your multiple hormonal and immune system um, type involvement. And so when her pregnancy occurred and her hormones and immune system changed and stabilized in certain ways, she actually saw quite a bit of improvement in her disease state and a decreased need for medications. So with this patient, after she delivered her baby, and during delivery, actually, there was a lot of concern about whether or not her pain condition would flare, how the pain would be managed during the labor and delivery process. And so what we recommended was just to do a standard epidural, and that ended up being fine. And then postpartum, then we worry about adding medications back on if needed, and whether or not those are contraindicated in breastfeeding. Um, Patients are going to have a conversation about whether or not they choose to breastfeed, how that process goes. Typically, if a patient is breastfeeding, we will try and choose pain medications that are as short acting as possible, and then use techniques like nurse and then administer the medication after, or pump and dump, that kind of thing. For my patient, she ended up choosing not to breastfeed and ended up doing formula only with her baby. And what was interesting was that, it usually takes about a year for a woman's body to sort of stabilize hormonally and get back to the pre-pregnancy state. And so for many months, this patient in particular didn't need any medications added back on. But once she hit the year mark, we slowly added things back one at a time to manage her pain. And she never ended up needing all of the medications that she was on prior to pregnancy.
So there's a growing recognition that managing pain isn't just about prescribing, it's about empowering. Non-pharmacologic approaches can be incredibly effective, especially when used early and in combination, a layering of therapy, so to speak. Physical therapy, cognitive behavioral therapy strategies, mindfulness, and acupuncture all have roles depending on the patient and pain type. The evidence base varies, but our openness to trying these approaches should not. Working in interdisciplinary settings myself, I see how collaborative interdisciplinary teams can transform outcomes. For clinicians, without those resources, partnering with community services or digital tools can make a big impact. It's about matching the right intervention to the right patient.
I think that in my practice, the non-opioid medications that we recommend most often are typically antidepressants and anti-epileptic drugs. In my practice, we deal a lot with neuropathic pain, with fibromyalgia. And so those classes of medications are extraordinarily important for those types of conditions. Duloxetine, for example, is a SNRI that has indications for um, musculoskeletal pain, fibromyalgia, and neuropathic pain. And oftentimes, patients with chronic pain also have concurrent depression or other or anxiety disorders. And so, using a medication like that also has indications for psychiatric conditions, can be incredibly helpful because we're sort of covering a lot of different indications at once. Similarly, something like pregabalin is an anti-epileptic drug that has multiple indications as well. It has indication for fibromyalgia, for neuropathic pain, and then it also, off-label has some anxiolytic effects as well. So whenever we can use non-opioid medications that have multiple indications and multiple uses, that's really helpful for patients with chronic pain. My experience with topical agents has been sort of mixed as far as their usefulness, depending on the condition. I find that topical agents aren't hugely impactful when decreasing pain scores, but they quote unquote help take the edge off in a lot of patients. So we might be able to bring someone's pain score down a point, maybe two, if they're having a really severe increase in their pain. Some of the typical topical agents that we frequently use in our practice are diclofenac gel, for osteoarthritis and, other related joint pain. There's quite a bit of stigma attached to opioid use and chronic pain. And in some cases, it's a bit warranted because of the current opioid epidemic and what everyone hears about opioid overdoses, and what's been going on for the past, decade and a half or so in the United States. And the way these conversations go with patients is I say, listen, there's a difference between having physical dependence on a medication and tolerance to a medication build up, and a difference between actual opioid use disorder or addiction. With long-term use of these medications, your body will require more doses to achieve the same therapeutic effect. So that's tolerance. And then your body's also going to become physically dependent on it, meaning that if we stop it abruptly, you will experience symptoms of withdrawal. So if you experience symptoms of withdrawal, that's not the same thing as being quote unquote addicted or having an opioid use disorder. That is when you actually have harmful behaviors associated with the medication use. You have drug-seeking behaviors, and I'll go through, sort of some of the DSM-5 criteria with them and explain that it's different.
So when it comes to initiating treatment with opioids for acute pain, my patient selection is normally based on the disease process. And so if someone has a surgery or they have an injury that appears to be severe, where there's actual tissue damage, then I feel that it's totally fine to prescribe opioids. The goal of acute pain treatment is often to ensure that you treat pain well, but you treat pain for a very short period of time. And so treating pain adequately, but titrating off, and also using kind of the potential other options as much as possible. And so that would include rest, ice, topical medications, and non-opioid analgesics. For acute pain treatment, if you prescribe opioids, you should prescribe opioids in a PRN manner and ensure that those patients have those other options, whether it be acetaminophen or ibuprofen or ice, and encourage patients to use those and only use the opioids when the pain is severe. Um, when it comes to naloxone, every state has their own laws. In Arkansas, if someone gets a new opioid prescription, they're required to have naloxone. But I think it's best practices to go ahead and give patients the option to have naloxone, not only for their protection, but for the protection of those around them. When it comes to acute pain management, I don't think that we should deprive patients of acute pain management, especially if we're providing short courses of opioids, if they have a risk or a history of OUD. And so I don't use the screening tools when I'm prescribing medications for after a surgery, for example. But if I am prescribing for chronic pain, where I know that these patients will be on these medications for a much longer period of time, and there's a higher risk of diversion or a higher risk of continuing those medications, then I will often make sure that I'm screening for opioid use disorder or risk of opioid use disorder. When it comes to the initiation of opioids for chronic pain, I normally use opioids for chronic pain as a last option. And so that's often when patients have failed all other therapies, and that includes physical therapy, that includes CBT, that includes other kind of non-conventional therapies like acupuncture or mindfulness. That also includes interventional therapies, as I'm an interventional chronic pain physician, and anti-neuropathic or adjuvant medications. When patients have no other option, I think opioids are a great option for them, but I think they have to be used judiciously. A lot of that patient selection, and really it involves a risk-benefit analysis because opioids are risky. And a lot of patients, unfortunately, have lost their life because someone decided to prescribe them opioids. And so that's why I think that risk screening is appropriate. I think a full understanding of the risk of taking opioids and having opioids in your home and the potential dangers to family members or friends who are around them is important to know. And oftentimes, when I'm dosing long-term opioids, I'll start again with PRN medications. But if patients dose escalate, then I start to use standing medications because I don't want patients to start kind of making decisions and taking multiple pills in a PRN fashion. I'd rather be much more prescriptive in when and how often they can take their opioids.
For patients who are taking opioids, either in the acute setting or for chronic pain, constipation is an incredibly common and bothersome side effect. Some side effects to opioids, such as drowsiness, we build tolerance to, but constipation, we do not. If you are on long-term opioid therapy and you're constipated in the beginning, there's no reason to think that that's ever going to end. So it's something as providers that we have to remember. We can't forget to address that side effect in our patients because it's so common and it's so important and bothersome. Um, in the acute setting, using a stimulant laxative such as Senna or bisacodyl in combination with a stool softener like Docusate is usually a tactic that works quite well. In the chronic pain setting, we often use stool softeners in combination with polyethylene glycol, and then we can also use stimulant laxatives as well. Typically, those are indicated more for short term, but for patients who are on chronic opioid therapy, we will still use those long term as well.
You know, as a palliative care physician, it's one of those things where empowering your patient to take control of their life with their disease states, their pain is just really important because I think that often our patients feel a loss of control. So whether that's tapering or weaning or going down to a different medication, I mean, there's just a lot of emotions that can come up with that. And so meeting them where they are is just really important and is going to drive better clinical outcomes if we can have them be part of the decision making.
What I've seen working as a dispensing pharmacist is that people will fill prescriptions under different names, and that way they kind of like work around the PDMP catch that we typically would be able to do. So there's still ways around it, but it is an incredibly useful tool that prescribers and dispensers all need to utilize.
And so, if patients continue to overtake medications, we often do urine drug screens. And sometimes a sign may be that patients actually don't have an opioid in their urine because they are overtaking their medications at the beginning of the month. Or if patients are continuing to dose escalate in a way that doesn't seems to be off the curve of the normal kind of escalation of pain. Then I'll often tell patients, and I try to be very real with my patients and honest and upfront. I do a lot of things like urine drug screens, checking the PDMP, signing opioid agreements, educating patients, writing naloxone. I do those things for everyone so that patients don't feel singled out. The second is if I see a concern, I voice it. And I'm very honest and I say, something like, hey, one of the things I've noticed is that on your kind of routine urine drug screening, I see that there wasn't any oxycodone in your urine. And given the amount of medication that you normally take, I normally would expect some metabolites to be there. And so I wanted to have a discussion about, did something different happen this month? Or is there something that's changed in how you take your medication? I try to ask from a place of curiosity instead of a place of accusation.
Changing opioid medications. Switching opioids can be one of the trickiest parts of chronic pain management. The concept of incomplete cross tolerance means that when you switch from one opioid to another, the new medication may have a stronger or weaker effect than expected. So I generally reduce the calculated equianalgesic dose by about 25 to 50% to account for this. The goal is safety, especially in older adults or those with comorbidities. I tell my colleagues these charts are a guide, not a rule book, or a tool, not a rule. We have to also monitor them closely in the first few days for sedation, confusion, or withdrawal. This is really a clinical art as much as a science. We have a downloadable resource to help with these conversions in your practice. Recognizing opioid use disorder can be nuanced, especially when it emerges during legitimate pain treatment. Early red flags might include requests for early refills, escalating doses without clear clinical reason, or withdrawal symptoms between doses. When I suspect OUD or opioid use disorder, I lead with empathy. I might say something like, sometimes our bodies adapt to these medicines in ways that can make it hard to stop, and let's talk about that. That framing keeps trust intact and opens the door to treatment options. Collaboration with an addiction medicine or behavioral health specialist is key, and warm handoffs make the difference, all the difference in the continuity of care. Addiction involves craving and continued use despite harm. I often explain it like this: dependence is expected. Addiction is when control is lost. This helps destigmatize the conversation and helps build understanding that OUD is not a moral failure, but a treatable condition. Screening early and often is one of our best defenses in OUD. I like to start with the Opioid Risk Tool, or ORT, at baseline, and then use COMM, for ongoing monitoring once treatment has begun. It's important to normalize these tools by saying, we do this with everyone who takes opioids. It's a part of good clinical care. That transparency reduces stigma and improves honesty. If a screen raises concern, I'll follow up with a focused conversation about safety, function, and goals, never blame. Applying the DSM-5 criteria for opioid use disorder in real-world practice means balancing thoroughness with practicality. We may not document every criterion in daily visits, but we should be alert for key signs like loss of control, craving, and continued use despite harm. Sometimes colleagues tell me that the DSM feels very rigid. My advice is to use it as a guide, not a gatekeeper. If a patient meets even mild criteria, early intervention can prevent progression, and that is success.
One of the challenges that I do notice, and this is specific to my state, and I imagine that a lot of you encounter it, is that there are not a lot of psychiatrists in Arkansas. I train in New York City, where I always joke that you could throw a rock and you could hit a psychiatrist. But here, we don't have that luxury in Arkansas. And so I'm fortunate that I have addiction specialists that are embedded into my hospital system. But I would encourage all of you, there are a number of telemedicine services that provide CBT, that provide other addiction services. Also, if you find that need, I would encourage you to find education. There's a lot of education that is on even the CME Outfitters platform or other platforms to help you feel more comfortable in starting buprenorphine treatment and treating patients who have opioid use disorder. Because by doing that, in that moment, that may be the one thing that is the best thing for that patient's overall medical care. And in the long term, you may save that patient's life.
When treating opioid use disorder, the combination of medication and behavioral support gives patients their best chance at recovery. Buprenorphine, methadone, and naltrexone each have unique advantages. I often explain that buprenorphine works by stabilizing the brain's receptors. It quiets craving without the highs and the lows. The recent regulatory changes, removing the X waiver and expanding buprenorphine dosing, are huge steps forward for access. Still, many of our patients face barriers, stigma, transportation, and cost. And that's where telehealth has been transformative. Our role is to keep the doors open, meet patients where they are, and remind them that recovery is possible and that we're in it together.
I think that when we approach a patient about tapering a dose of a medication that they've been on for a long time, especially an opioid analgesic, it can be a really sensitive conversation. There's a lot of fear and nervousness when it comes to pulling back on medications that have maybe worked well for patients for a long time, that they've relied on to do their activities of daily living and live their lives, or maybe they've gone down that road before elsewhere and it hasn't gone well. So sometimes those conversations are difficult to approach, and they don't go well unless you have built trust with the patient already. And some of the ways that I talk about it are, bringing up the idea of tolerance. I'll say something like, you've been on this medication for a long time. We're not even sure how much it's even really working for you. And you might even feel better if we taper it. And I'm going to go really slow. I'm going to be here with you every step of the way. We're going to work together. And I find when it's done in that way, in sort of a trust building, shared decision making approach, it usually goes much better, and patients are a lot more receptive to talking about tapering their opioids. But it is still a very challenging discussion. And it also depends how fast you need to do it. So in my practice, usually we're tapering just because someone's been on it a long time, not necessarily because of a risky behavior or something else urgent that has come up. But when we do have to taper quickly, that is a little bit more difficult. Like if someone all of a sudden becomes pregnant, or something illicit comes up on their urine drug screen, and then we just have to do it quickly. And so that's a little bit more challenging. We have data that says that people who were using opioids for non-medical uses were most commonly getting it from a friend or a relative for free, which makes sense because for many, many years, hydrocodone acetaminophen was the #1 prescribed medication in the US as far as number of prescriptions. And for a long time, we kind of thought, oh, that made sense. Like everyone has that bottle of hydrocodone acetaminophen in their medicine cabinet that they got from a dentist or a doctor or whatever prescriber that they saw for a pain condition. And so it's really important to counsel patients on um, the safe storage of their medications and also disposing of them. So whenever I am at the pharmacy and dispensing an opioid, I always counsel patients that whatever they don't use, whatever is left over, needs to be disposed of. And then I give them resources to do that, either by drug take-back programs locally, or for example, where I practice, the sheriff's office has a bin, a drop bin that people can drop their unused medications in. There's also mail back envelopes that you can obtain from a local pharmacy, or the DEA has drug take back days and community events and things like that. So just patient education on that is really important because we want to minimize the amount of opioids that are just out in the community in general. And then in addition to safely storing them. I'll give you another example as well. I had a patient who was traveling to Japan for 3 months, and she had to take an entire 3 month supply of her fentanyl patches and her oxycodone acetaminophen tablets. And so this was a very large amount of opioids that she was traveling with. And so we did a lot of education about the importance of securing it, either in a locked area of her carry-on, the safe in her hotel, or having some other way to lock it up while she's traveling. And the same goes for people at home. We don't want anyone to have access to potentially dangerous medications who should not have access to them. So a lot of patient education on storage and